So, dear colleagues and my young fellows, we were discussing about tips and tricks of anastomosis, gastric bypass. So, as I have talked, so when you are going to insert your these standardized this trocar side, so first of all, you must insert your gastric tube in supine position, then this position, that is 45, and then you will insert these trocars. So now next step is liver retraction. For liver retraction, so you must use two trocar. Overall, I prefer for this one locking grasper, because from this xiphy or this sub-xiphy trocar, that is 5 millimeter, I insert here, but with the help of my left hand. So from this trocar, so I retract liver, and routinely I use single action fenestrated trocar here. So you can insert here this trocar, and you can retract your this liver lobe upside, and then you can grasp that the tissue, soft tissue at EG junction, and you will do this liver retraction. This is second or third step. So next step that routinely I prefer, that is his angle dissection. So this his angle dissection is also very important. Why this is important before going to do other steps? Because when we will do this, we achieve two targets. First of all, we can easily rule out any hiatal hernia. If we have hiatal hernia, especially hiatal hernia is larger than, because sometimes you miss in endoscopy, and routinely we will not do endoscopy for all of the patients. So we can miss this, we can detect now. So if this his angle, and we can detect hiatal hernia larger than 4 centimeter, then I prefer to repair this. So due to this, I prefer a single dissection one. And second one, when you will go and you will do this gastric pouch, your last stapler, when you are going to do that last stapling of your last stapler, then it will be very helpful. What I do here, so routinely how I do this, so this is my left hand, I use at this step my single action grasper. So I also take some assistance with my assistant. So I take omentum from here, because there is omentum. Yeah? When you will see omentum is here, because patient is morbid obese. So I grasp omentum, retract like this, just this position, and be careful, because this omentum and this also attached with spleen. Don't traumatize spleen, never go harsh here. So this meticulous and very gentle, so this movement manipulation. So when you go here, come here, so like this and hold here, so your assistant will hold, you have some space, then you can grasp this fundus with the single action, and you can retract like this movement. When you retract, you will grasp here fundus, this retraction, this movement, then you can see easily. And so your this camera easily you can, and also because if you see the code, so this must be, because camera like see always, because this 30 angle you can see here, when you rotate your code, so you can see that side. So this must be about this angle of camera, so you can easily, because straight maybe you cannot see, but when literally rotate here, then you can see easily that angle, and then you can dissect that. I prefer routinely ligature I am easy, harmonic is also good. So then you can dissect, and when you will just, you can grasp that is a web, that is a area, this EG junction, that is avascular. Just when you will cut, and then just with that tip of this ligature you can dissect, and you can see yes, there is a space. So this no need to a lot of dissection, just 2 or 3 this bites is sufficient, and then you can see yes, you have a space here. What I do routinely, I put a gauze there. That gauze is also for hemostasis if there is little bleeding, as well as this will be guide when I will go for last stapler. It will help me, I will follow that gauze, and easily, then there is no chance of trauma to splenic vasculature at that point, especially when we are dissecting for our last stapler. This is our liver retraction, esophageal dissection. Now next step, that is also very important, we must rule out any adhesions of small bowel. So routinely I rotate my camera and I will check, yes, intestine. I never measure at that step, but I see, yes, I can easily mobilize my intestine. Then I must go for my gastric pouch. So when I do this, so next step is for my stapling of my first stapler. That is very important and one of the most important point. So what I do, I use, so this is my trocar site. So if you imagine, this is our stomach. So we can see this is our stomach, and what I do here, this is our stomach here, this is our stomach, and you can see this is lesser omentum. So here is pylorus, here is pylorus. So when we hold this one here, so because our first stapler must be here, this is our first stapler. So I can see this is pylorus. From pylorus to first stapler, 3 to 4 centimeter. You can also see crowfoot. So this is below crowfoot. So you must, so there are two landmarks. Also crowfoot we can see. Also we can see pylorus. So our first stapler must be perpendicular to our antrum at this point. So how can we adjust here? First of all, we need a window. This window we need here, this is lesser omentum. With 2 or 3 bites we can do, no need to damage vessels, because if you will dissect more, then your tip will be ischemic, and again this will be issue in future and maybe marginal ulcers and other issues you will face. So no need to dissect more, and be careful, don't traumatize this stomach wall. So again I prefer here ligature, that is more safer for me. So harmonic is also good. So we make this window, we confirm pancreas beside, and then you will go again. You need a help from assistant. Assistant will hold here antrum and stomach like this traction, and then you will hold with your left hand this lesser omentum. This traction will give you the space and you will dissect here. Your first stapler must be from this trocar. When you will do, yes, you can manipulate, because routinely here we use articulate. So you just, when you will go, because this articulation is 60 degree routinely, then when you are here and this thick part of your stapler must be behind this. So when you will do this like this, and then you will rotate here, and again you can angulate this one. This angulation is doable. This angulation is doable. So you can angulate just like this, and you can put here perpendicular to the antrum. So another point, so this size routinely I prefer 60. So you can do also with 45, but I prefer 60, but I adjust here because 60 is longer than antrum. And also which color, again it depends on your patient, because antrum is thick. So in patients, male patient, I prefer maybe green, I prefer tri-stapler, black. So it depends on the patient, because this thick. So this stapler selection is very important, and just and straight, because if nip will be sharp, so again chance of ischemia. So this must be like this. So when you are going to staple, be careful this space. Never cut completely, because we need this space for drainage of this remnant. So this is also another point. Then second stapler, when we staple it, another point, when you are going to staple, every shot you must wait at least for 20 seconds. You will staple and then wait, then you wait for 20 seconds, and then when you will complete your stapling and out, okay, you must rule out any bleeding. You must be prepared for bleeding. You must have all clips, everything ready for if there is some issue. At this situation, always I put a gauze there before going to staple. So my gauze is there, I am ready. If any issue, I can press that one. So after that, so our second stapler, so also before going to second stapler, I must see any adhesions there. So I rule out adhesions. So if there is no adhesion and I have space at retrogastric area and I can staple, again my second stapler is with my left hand from right side of the patient. Again I prefer, so maybe I prefer, because this is the antrum and this is the thick part of the stomach, I prefer green, I prefer here tri-stapler, black. So it depends on the patient and also male, female. So routinely male patients, this is thicker than female patients. So my second stapler is also routinely I use all of my 60 and also articulate here and from my left hand and right side of the patient, and then now I rotate upside. So during this period, when I put here, first I staple, okay, no issue. Till this time my bougie is not inside my pouch. This second stapler, I stapler. Now I have started to make pouch. At this stage, I guide my anesthesia to put bougie inside this small pouch. Then I start to make this gastric pouch little wider because my bougie is 40. So just touch, never I tight this bougie, because this is the variation that is not like one anastomosis gastric bypass. Because in one anastomosis gastric bypass, Professor Carbajo prefer a tight, narrow pouch, but we prefer little wide because in our areas are different. So I cannot make a surgery with more restriction and also strong malabsorption. So my restriction is lesser than Professor Carbajo. So pouch is also little wider and also relax. So then I start my next staplers from this one. So then we continue and also dissect, and also I need the help of my assistants. So my assistant tent that area and I can see behind, and also with the help of my cameraman with different angles, so we can see and I dissect, because there is some adhesions with pancreas, because these patients are suffering with hyperlipidemia. Also maybe they have experienced some type of pancreatitis and some adhesions. So be careful. We have also here splenic artery. So also be careful for dissection. Then we'll go, and no need to more dissection. Just make a window and staple. And also when you are going to staple, be careful. So your this staple must be this. So because they have some pouch behind, so no need. So again you can adjust your stapler and you can go for, so this last stapler, again this last stapler is very important. When you will make a window here, so your assistant will help. So this tenting by your assistant is very important. Then you have a good vision. So with tenting of your assistant, so you can make the window easily. Always a gauze is in your hand if any issue, and there we have at least one short gastric. That is very, like this ligation of this short gastric is very important. After the ligation, and when you will confirm, so there is no issue, no problem, then you must chase your gauze. That gauze you can see also upside, yes, where you are going, because always recheck your position. Sometime we will go here, when we are dissecting we will go here, that is also dangerous. So also we can go here to spleen, also dangerous. We must see where are we going. So you can check yourself from upper side and also this posterior of this stomach, and we must chase our gauze. When you will detect our gauze, everything is okay, then you can remove your gauze from that side. And also this grasper of your assistant must be inside that window and then retract. Then you can see and you can easily, yes, when you are going to staple further. So here you can use blue because this thickness is lesser. You can use here tri-stapler blue, but first these staplers are very important. This is our pouch. So next, now you can see you have a long wide pouch ready, and if you want to see your pouch is standard or not standard, at the end you must see like this. Your pouch must be like this. If your pouch is like this, yes, then you are okay, because this is very important. Your pouch must be like this. If your pouch is straight, if your pouch is like this straight, so then it means you are shorter, because if you will start from here from antrum, so then your pouch must be like this. This is very important. Your pouch must be like this. We must have such, and this end must be not like this. Sometime it is like this. So this, then it will be ischemic, and then there will be issues. So now if we see this gastric pouch, this is sometime what we see here, we see like this. So this is not good. It means your first stapler and also your second stapler, especially first stapler, was not standardized because it was not perpendicular to your antrum. This is very important. So your standard pouch is like this. When you have this pouch, yes, now you need, so you must, because for further gastrojejunostomy, so you need gastrotomy. So how you do gastrotomy? Here you need the help of again also your anesthesia. Also you need, and another thing, when we are going to staple this, always your anesthesia move your bougie. So bougie is not tight, everything is okay, you are not just, so always every stapler you must check your bougie and movement of bougie. And now again you need the help of your assistant as well as your anesthesia. Anesthesia will push the bougie inside with little pressure. So bougie, what will happen now here? Bougie, this is your bougie. So when you will pressure your bougie, it will straighten this. So now it will be little. So when your bougie inside, so how, what will you see here? You will see like this. Your pouch is now straight because due to bougie, due to pressure of bougie, now this will be your pouch. So inside bougie, and at this stage, your assistant will grasp this area, will fix this area, because your gastrotomy must be medial, if this is medial, and posterior of a stapler line, not anterior of posterior line. Never I cut a stapler line. I also hold this one, because I have single action fenestrated. I hold my gastric pouch here, little rotate. When I will rotate like this, so I can see the posterior line of my gastric pouch, and my assistant hold here, so easily I can access the posterior of my gastric pouch. Then I can just make here gastrotomy with monopolar, so this hook. So I routinely use monopolar hook here, and at the same time, so when I make this, then I dissect with my single action another, and so confirm, yes, I am inside. Then I ask to my anesthesia literally pull upside, because if I will not pull, so gas will be out from here, out, and everything is okay. Now we will go for this measuring of our small bowel and our further step. So in my next video, I will explain so how I measure my small bowel, how I make my gastrojejunostomy, which type of stapler I prefer, and how I suture, how I handle, how I fix my this gastric pouch, and then leak test and further steps I will discuss in my next video. Hope these are my videos will be beneficial and fruitful for you. See you in my next video. Thank you.